Good morning. I am one of the exam candidate. I have read the scenario, understood the scenario regarding the preoperative gynecology theatre list prioritization. I will now proceed to assess each patient room wise. After evaluating all four cases, I will prioritize then based on clinical urgency, patient safety, and available resources. I will explain any reasoning at the end of assessment. So, my first patient, Tracy, 32 years old, BMI 27, blood group A negative, para 0 plus 2, IVF, LMP 6 weeks ago, complaint of pelvic pain, bleeding, and scan shows empty uterus for the DNC. So, likely ectopic pregnancy, possible ovarian stimulation syndrome needs urgent assessment to clarify this differential diagnosis. So this patient present with an empty uterus. This is room number 1, likely ectopic pregnancy. The patient present with an empty uterus, we have no information about the urine pregnancy test or beta HCG. First, we need to confirmation of pregnancy via UPT or beta HCG. Second, the hemodynamic stability of the patient is unclear. If unstable, resuscitation with the fluid is priority. My differential diagnosis includes ruptured ectopic pregnancy, complete miscarriage, ovarian hyperstimulation syndrome. Although ovarian hyperstimulation syndrome is not is less likely, but she is 6 weeks. It's only 6 weeks, so it's better to also keep OHSS in mind as well. So, if ectopic pregnancy is suspected and confirmed, then the patient is unstable. Proceed to emergency laparoscopy and salpingectomy. If stable, consider elective management. If OHSS, ovarian hyperstimulation syndrome, is the cause, management focuses on the fluid resuscitation and observation. So, test needed in this case is special test for evaluation: full blood count, renal function, early resuscitation, prioritize blood availability, assess the signs of shock, urgency increase significantly if the patient is in shock. So, at this stage, this procedure is not yet appropriate and require further evaluation. My patient, room number 2, large ovarian mass. So the patient is a large young patient, 18 years old, BMI 18. It's a low BMI, large pelvic mass, large ovarian cyst, CA 125 45 international per unit ml for laparoscopic oophorectomy. So the patient needs the other tumor markers because CA 125 is not an appropriate in this age group. For the assessment, alpha fetoprotein, HCG, LDH inhibin can be helpful. Appropriate scan by the specialist MRI. Any red flag sign of malignancy. So I will read her case notes. Refer for the multidisciplinary team for the surgical recommendation. A young patient present with a large adnexal mass. Assessment required to determine the nature of mass, simple, complex, or suspicious. Imaging MRI is preferable. Consider tumor markers, as I have already explained. Which tumor markers? MDT review required, especially with the oncology input. Decision regarding the surgery, cystectomy versus oophorectomy, will depend on multidisciplinary team assessment and malignancy risk. Currently, she does not require theatre. She needs further evaluation. So, this is also at this stage, this procedure is not yet appropriate and require further evaluation. Case number 3, room number 3, contraception with the comorbidities. So this patient has a requested sterilization. She has a history of DVT, obesity. Cardiologist opinion is crucial because she is having history of subacute bacterial endocarditis, DVT, wants laparoscopic sterilization. The history of DVT and obesity, cardiologist opinion, cardiac function due to possible hormonal contraindications. Discuss alternative contraceptive options including vasectomy as well. Vasectomy if her partner is willing for the vasectomy. If sterilization is still preferred, laparoscopic procedure can be planned post cardiac clearance. She had a recent termination of pregnancy. Ensure antibiotic prophylaxis and thromboprophylaxis are addressed. This patient is elective but high risk due to comorbidities. My fourth patient is anemia evaluation. So in case she is 45 years old, fibroid uterus, menorrhagia, hemoglobin 8.1, GOA witness for myomectomy. So check recent hemoglobin, give oral iron, GnRH analogs, advanced directive, availability of the cell salvage due to because she is a Jehovah Witness, counsel regarding hysterectomy if she completed her family. Consultant must be present, senior anesthetist and hematologist review should be done. So this patient is not bleeding currently. She present with the anemia requiring correction. Investigation and treatment for underlying cause are needed. She is clinically stable and can wait. Now I will prioritize. Room number 1 is the first priority, is my first priority. Possible ectopic pregnancy, unstable, life threatening. My second priority is room number 3, because although she is stable but she is a high risk with the comorbidities, needs planning and specialist review. Room number 2, third priority, requires investigation and MDT input but she is stable. Room number 4 is my fourth priority, last priority, because she is stable, anemia needs correction but it's not an urgent case. So and room number 1 and room number 2 are the inpatient should be done in the inpatient facilities. Room number 3, which is laparoscopic sterilization, it can be done in the day unit. And room number 4, which is also in inpatient, this procedure is also an inpatient procedure. So this is all about preoperative gynecology list. Thanks.